Pleural effusion are of two types, exudative and transudative. Exudative causes are always pathological. Exudative causes are always pathological. That means it indicates involvement of the pleura or lung. As well as left-sided pleural effusion is almost always pathological because the benign causes of pleural effusion usually causes right-sided or bilateral pleural effusion. You will understand a little later. So exudative causes are tuberculosis, malignancy. Primary malignancy means bronchogenic carcinoma, and secondary malignancy means metastasis from other side into the pleura, pneumonia, pulmonary infarction, lymphoma. And liver abscess causes right-sided pleural effusion, pancreatitis causes left-sided pleural effusion, and SLE. These are the disease involves the pleura, causing pleurisy, pleural inflammation or pleural allergic reaction, and causes accumulation of fluid in the pleura, and so it is pathological. And when the causes are transudative, these are congestive cardiac failure and hypoalbuminemia due to any cause. The causes of hypoalbuminemia are nephrotic syndrome, CLD, malnutrition, malabsorption, protein losing, enteropathy. My handwriting is poor, but try to understand, please. And hypothyroidism also transudative. These are the disease does not involve the pleura and does not causes pleural effusion by direct invasion, but causes accumulation of fluid by other mechanism. So transudative are benign pleural effusion, and this is always pathological pleural effusion. There are several types of pleural effusion, such as hemorrhagic pleural effusion, chylous pleural effusion, and empyema, purulent pleural effusion. So hemorrhagic pleural effusion are carcinoma, trauma. Trauma means patient may have trauma and there is hemothorax, or you may give trauma during puncture of the chest through the needle, and also pulmonary infarction. So carcinoma and pulmonary infarction, trauma, these three are hemorrhagic. And chylous due to trauma or surgery of the thoracic duct, malignancy involving the thoracic duct, lymphoma involving the thoracic duct, or filariasis. So malignancy, lymphoma, and filariasis, these three causes are chylous pleural effusion. And empyema means frank pus in the pleural space. These are pneumonia, lung abscess, and tuberculosis. Pneumonia and lung abscess causes accumulation of pus in the pleural space and associated with high fever with chill and rigor and weight loss and clubbing. But in case of tuberculosis, the patient may be asymptomatic or vague symptom, or fatigue, weakness, anemia, weight loss, and low-grade evening rise of temperature. So it is cold, but it is hot, and this empyema is hot. I think you understand this. Now regarding the investigation, CBC and CRP. CBC, CRP will be high in case of pneumonia and lung abscess, and total count of WBC will be high in case of pneumonia or lung abscess associated with empyema or parapneumonic effusion, and there will be neutrophilic leukocytosis. You understand? And there will be normochromic normocytic anemia or anemia of chronic disease in case of tuberculosis, malignancy, lymphoma, or SLE, etc. And chest X-ray, you will see the extent of pleural effusion. You may find collapse, you may find tuberculosis, you may find pneumonia, or the causes. Okay, post aspiration X-ray, it is very much valuable. When you, after aspiration of 1500 ml maximum in one setting, pleural fluid aspiration, you will do an X-ray that will show the lung field that reveals after the aspiration of pleural fluid. This may show evidence of collapse, evidence of bronchogenic carcinoma, evidence of pneumonia or tuberculosis, etc. And then if the patient produces sputum, you send sputum for AFB staining, gram staining, culture sensitivity, both bacterial and mycobacterial. Mycobacterial culture sensitivity is given in Lowenstein-Janssen media and takes 6 weeks to find out the mycobacterium. And cytology, cytology means malignant cell, cytology for malignant cell. Okay. Then ultrasonography, I have involved this. Many textbook does not shows ultrasonography as an investigation in case of pleural effusion, but I have shown here. Listen, what is the cause? Ultrasonography will show lymph node in the abdomen that may be due to tuberculosis or lymphoma, multiple sol, that is space occupying lesion in the liver in case of disseminated malignancy, and splenomegaly of SLE, CLD or lymphoma, and etc. So it is very much valuable, I think. And pleural fluid aspiration and study, you will see the amount. You cannot aspirate more than 1500 ml, that means 1.5 liter at a time, because if you aspirate more than this will lead to as post aspiration re-expansion pulmonary edema. It is very difficult to control. So okay, color red, we have already described the causes of hemorrhagic pleural fluid, and white chylous pleural fluid, it is discussed. Clear in case of nephrotic syndrome, malnutrition, malabsorption, protein losing enteropathy, congestive cardiac failure, and straw in case of tuberculosis, and purulent in case of accumulation of pus. And then you will send the fluid for cellular examination, RBC in case of hemorrhagic, WBC, lymphocyte count will be raised in case of malignancy or tuberculosis or lymphoma, but neutrophil count will be high in case of pneumonia or tuberculosis, pneumonia or lung abscess, eosinophil will be high in case of pulmonary infarction, and malignant cell will be found in malignancy. And now biochemical, glucose and protein will be low in case of bacterial and malignant diseases. ADA will be high in case of tuberculosis, and amylase will be high in case of pancreatic left-sided pleural effusion. And pH, if it is less than 7 associated with empyema, it is very important. When there is empyema and pH less than 7, it is indication of drainage. And then microbiology, you send the pleural fluid for gram staining, AFB staining, culture sensitivity, both bacterial and mycobacterial already discussed. Then you will send serum protein, total protein, and pleural fluid protein. You see pleural fluid protein and serum protein ratio, if more than 0.5, that means pleural fluid protein 3.5 gram per dl and serum protein 6 gram per dl. The ratio between these is 0.53, sorry, it is 0.53. So if it is more than 0.5, it is exudative. If it is less than 0.5, it is transudative. Pleural fluid LDH is 110 unit per liter. Serum LDH is 150 unit per liter. This is made an example, and it is 0.73. So pleural fluid LDH and serum LDH ratio, if more than 0.6, it is exudative. I have made this example to make it exudative. Pleural fluid LDH, look, pleural fluid serum LDH is maximum 150 unit per liter, and pleural fluid LDH is 110 unit per liter. So it is more than two-third of serum. Pleural fluid LDH is more than two-third of the upper limit of normal serum LDH. It is also exudative. You know, exudative causes are dangerous, and exudative causes are very much dangerous. And pleural biopsy, that means as there is pleural effusion, obviously the pleura is involved, so you must take the sample of involved pleura. This may be taken by needle biopsy, or maybe Abraham needle biopsy, or maybe thoracoscopically by directly visiting the involved pleura. You will send it for histopathology, AFB staining, gram staining, and culture sensitivity for mycobacteria. If you find a lymph node in case of tuberculosis in a patient with pleural effusion, you must send it for histopathology, culture sensitivity, and AFB staining. Histopathology will show it is either primary lymphoma or disseminated malignancy or tubercular, etc. And CT chest will show you the presence of lymphoma, staging of lymphoma, and evidence of bronchogenic carcinoma. If you find a patient with a pleural effusion and no mediastinal shift, that means trachea is here, heart is here, lung is here, one lung is here, and there is pleural effusion massive, but there is no shifting of the mediastinum, you think that lung has been collapsed. So collapsed lung always indicates central bronchial obstruction. Central bronchial obstruction, you will do a bronchoscopy for collapse, and CT guided FNSC from the lung tissue if there is no collapse but peripheral bronchogenic carcinoma. CT guided FNSC of lung field, ANA and TDS DNA and urine RE for SLE, serum albumin, TSH, serum creatinine, ECG, echo 2D for cardiac and other causes, and low albumin. If you find low albumin in case of pleural effusion, you have to find out the cause accordingly, because the causes are nephrotic syndrome, CLD, malnutrition, malabsorption, protein losing enteropathy, and also in chronic diseases. Thank you very much.